Good evening, everybody. Thank you very much indeed, and welcome to this evening's extraordinary governing body meetings of both North Derbyshire and Hardwick Clinical Commissioning Groups, or CCGs. I'm Ben Milton. I am the Clinical Chair at North Derbyshire CCG, and I'd like to introduce Jill Dentith, who is the lay member for audit and is the Deputy Chair of Hardwick CCG, with apologies from my colleague Steve Lloyd, who's the Clinical Chair at Hardwick, but Jill will be chairing this evening's meeting on behalf of Hardwick in Steve's absence. As I say, we've got two governing bodies here this evening. Please bear with us for some slightly complicated governance logistics. We have two governing bodies who are required to make independent decisions this evening. So what we will do, for those of you who've been able to see the agenda in advance, is run through the presentation, having gone through the usual sort of business of a public meeting. All together, we'll have an opportunity for the governing body members present to ask questions and also to receive some public questions. And then we will separate out. So first of all, North Derbyshire CCG will retire and Hardwick will consider their decision, and then we'll swap over and North Derbyshire will come back into the room and Hardwick will retire and we'll consider our decision. First few points of business, if I could. Just the usual housekeeping rules, okay. There are toilets back outside in the main foyer should people need that during the course of the meeting. There are no planned fire alarm tests this evening, so if the fire alarm sounds, please do exit the building as swiftly as possible. Okay? There are fire exits. I'll do my best flight attendant impression for you, but there are exits behind everyone down at the far end of the room. There are also a couple on either side here as well, so please use those if necessary. If anybody requires any assistance to exit the building, please identify yourself as quickly as possible by raising your hand. There are a number of staff of both CCGs around the room tonight who will be able to assist anyone if necessary. Jill, do you want to take over?
Good evening, everybody. I'd just like to confirm, as Ben said, that this is an extraordinary meeting of the governing bodies of both Hardwick and North Derbyshire, and it will be a single item on the agenda, which is considering the 21st century proposals around care closer to home.
So again, just as a clarification, both governing bodies hold their meetings in public, and it is normal to do that so that the general public can observe the discussions and the decision-making that take place. It's not, however, a public meeting as such, so unfortunately there isn't an opportunity to ask questions this evening as there was at the consultation meetings earlier on this year. Again, a number of you will have seen that we took questions in writing before the meeting, and what we will do is read out a selection of those this evening and provide the answers. Obviously, with such a level of interest around these proposals, we received an awful lot more questions that we're going to have time to be able to answer tonight. But what we will do is answer all of those questions to the individuals who submitted them within 20 working days, and then we will compile that full list of questions and answers and put them up on the website for anybody to see, so that we're completely transparent with regard to that. If anybody for any reason wouldn't want their question to be posted in public, perhaps if you could identify that to us after the meeting, and we'll happily take that into account. You've all been incredibly respectful so far this evening, and I'm incredibly grateful for that. I think it also marks the level of conduct that everybody showed throughout the consultation process last year. We do appreciate very genuinely, and hope you'll understand this evening, the gravity with which both governing bodies understand and hold this evening's decisions in. I am just reminded to say that with respect to it being a public meeting, there is provision for the chairs to exclude the general public should they have to in order to complete the business of the meeting. So I hope it won't come to that, but I would just ask politely that you respect that through the course of this evening. So thank you very much indeed.
Just to make you aware, hopefully you can hear us okay at the back, yes? Yeah, okay. The meeting is being filmed and live streamed, and we have a number of members of the press here who may take photographs during the evening. But in relation to the members of the public and to governing body members, I'd ask that you turn your phones off or onto silent, that there's no recording on phones, and that we continue with the meeting without interruption. Thank you.
Okay, so on that note, what we'd like to do now, obviously there are some name cards in front of governing body members, but for those who can't see those, just ask the rest of the governing bodies to introduce themselves. So starting with North Derbyshire, I'm going to pass over to Steve Allinson.
Hello and good evening. My name's Steve Allinson. I'm the Chief Officer and the Accountable Officer for the North Derbyshire Clinical Commissioning Group.
Hello, I'm Suzanne Pickering, Head of Governance for North Derbyshire CCG.
Good evening. I'm Mick Cawley. I'm the Interim Chief Finance Officer for North Derbyshire CCG.
Hello, my name's Jane Stringfellow. I'm Chief Nurse North Derbyshire CCG, and for the sake of clarity, I'm also Interim Chief Nurse at Southern Derbyshire CCG and Derry Wash CCG.
Hello, my name's Debbie Austin. I'm a GP in the High Peak and I sit on the governing body of North Derbyshire CCG. I'm a voting member.
Hello, I'm Isabella Stone. I'm a lay member for patient and public involvement on North Derbyshire CCG, and I'm a non-voting member.
Ian Gibbard, lay member with North Derbyshire CCG and a voting member.
Good evening, Gary Apsley, lay member with North Derbyshire CCG and a voting member.
Sorry, my mistake. I forgot to ask the first few people to clarify whether they were voting or non-voting members. So just for clarity, Steve, Mick and Jane are voting members of the governing body. Suzanne isn't.
So we're going to go through a similar process in terms of Hardwick governing body, members and those who sit in attendance. For those people who are members of the Hardwick governing body, they are all voting members. But we do have some people who sit on at the meetings who are in attendance, and they'll introduce themselves, their name and their role.
Okay. Thanks, Jill. Good evening, everybody. Thanks for coming along tonight. Andy Gregory, Chief Officer, Hardwick CCG and voting member.
Karen Watkinson, Corporate Secretary, Hardwick CCG, non-voting member.
Good evening, Miles Scott. I'm the Chief Finance Officer for Hardwick CCG and I'm a voting member.
Hello, I'm Ruth Cooper. I'm a GP and I work in Tibshelf, Staff Health in Tibshelf in the south of the Hardwick CCG area.
Good
I'm
evening.
a voting member, sorry.
Sorry. So, hello, I'm Jim Connolly. I'm Chief Nurse at Hardwick CCG and I'm a voting member.
Good evening, I'm Dr. Sudeep Chowra. I'm a GP working in Wingworth and I'm a voting member.
Hello, my name is Clive Newman. I'm Director of Transformation for Hardwick CCG and I'm a non-voting member.
I'm Dr. Lucy Morley. I'm Secondary Care Doctor on Hardwick CCG and I'm a voting member.
Hello, I'm Jill Owen. I'm the lay rep for public and patient involvement with Hardwick CCG and I am a voting member too.
Good evening, my name's Gareth Harry. I'm Chief Commissioning Officer at Hardwick CCG and I'm a non-voting member.
Okay, thank you very much, everybody. Next part of business is to ask for conflicts of interest with regards to the agenda. So first of all, I'd like to ask Suzanne to confirm the North Derbyshire declarations of interest, please.
North Derbyshire CCG publishes its register of interest in line with the NHS England Managing Conflicts of Interest revised statutory guidance for CCGs. Governing body members who have an interest in a specific item on the agenda are required to declare their interest at the meeting. In respect of today's decision, Dr. Austin, our Deputy Clinical Chair and Governing Body GP, has declared an indirect interest, as her spouse is employed by Derbyshire Community Healthcare Services. In line with the CCG's conflict of interest policy, the potential for a conflict of interest has been reviewed by myself as Head of Governance and the CCG's conflict of interest guardian, and we have agreed that Dr. Austin can participate in the discussions and the decisions, as there is no direct impact on Dr. Austin's spouse's role and therefore no conflict. It has also been raised as one of the questions, as Jane Stringfellow is a governor at Chesterfield Royal Hospital. There is a role as a CCG employee, and the Trust requests governors to be representatives on their board, and therefore this is not a conflict of interest.
Thanks, Suzanne. Sorry, could you also just confirm any apologies for tonight's meeting and also the choruses reached by the governing body?
North Derbyshire CCG has apologies from Dr. Bruce Braithwaite, Eleanor Rutter, Dr. Praveen Allah, and Roger Miller. And I can confirm that North Derbyshire governing body is quorate with the members present.
Thank you, Suzanne. I'm going to ask Karen Watkinson from Hardwick to just again confirm any apologies we have for tonight's meeting, any declarations of interest, and to confirm that the meeting is quorate.
Thanks, Jill. The apologies that we have from Hardwick tonight are from Dr. Steve Lloyd, our clinical chair, Julie Voller, and Maureen Whittaker. But I can confirm that the meeting is quorate with the members that are present. In terms of our conflicts of interest, Hardwick CCG publishes a register of interests in line with the NHS England Managing Conflicts of Interest revised statutory guidance for CCGs, and governing body members who have an interest in a specific agenda item are required to declare their interest at each meeting. In respect of today's decision, Andy Gregory, Chief Officer of NHS Hardwick CCG, has declared an indirect interest as his partner is employed by Derbyshire Community Health Services. In line with the CCG's standards of business conduct and conflicts of interest policy, the potential for a conflict of interest has been reviewed by myself as Corporate Secretary and the CCG Conflicts of Interest Guardian. We have agreed that Andy can participate in the discussion and decision as there is no direct impact on his partner's role and therefore no conflict. In addition, Clive Newman, Director of Transformation and Clinical Programmes for Hardwick CCG, has also declared an indirect interest in this item. Clive's spouse is the Chief Executive of Derbyshire Community Health Services. However, Clive is not a member of the governing body and will not therefore have a vote in the decision of the governing body. So the conclusion of the Corporate Secretary and the Conflicts of Interest Guardian is that the interest declared does not preclude Clive from participating in the presentation of the post-consultation process and business case and providing information to the meeting. That concludes the Hardwick CCG declarations of interest. Thank you.
Thank you, Karen. So, we're on to the part of the evening where we'd like to look at the questions we've received from the general public. As I say, apologies that we weren't able to take these directly from the general public this evening, but given the level of interest and the number of questions received, we felt this was a fairer way of doing it to make sure we picked a reasonable cross-section of the questions received. But we will be publishing all questions with your permission and all answers within 20 working days. So please do keep an eye out for that, and you'll be able to see either your own question or the questions of others answered in full. I'm going to ask the PPI members, the lay members for Patient to Public Engagement to ask the questions. And first off, I'm going to ask Jill Orwin to ask a question, please.
Good evening. This question was sent in by Sarah Nash, and it goes like this. As a staff governor for DCHS, we had been told that the papers for today's meeting, 24th of July, needed to be published 7 days in advance of the meeting to meet consultation requirements. Also, to allow time for people to read the papers and submit relevant questions. The papers have actually been published 5 days prior to the meeting. I'd like to ask why the 7 days notice had not been given and if the meeting will still go ahead on the 24th today in light of this.
Okay. Yeah. Thanks, Ben. Thanks, Jill. And thanks, Sarah, for the question. So clearly the meeting is going ahead. There's no legal obligation on CCGs to publish 7 days before, but it was an ambition that we had and we wanted to be able to do that. We did do it within 5 days as the question poses. And I think importantly for the audience to understand and governing body members to understand tonight is the actual notification of this meeting went out on the 3rd of July, which is some 3 weeks prior. So we think that's significant notice and probably pays credit to the large attendance tonight.
Thank you. Gary.
This question is from the Matlock Hospitals League of Friends, Pam Wildgoose. It's addressed to both CCGs, and the question is, once decisions have been made on the Better Care Closer to Home consultation, what are the ways in which organisations and individuals can appeal against any of those decisions?
Thank you. Thank you, Pam. So neither of the governing bodies, Hardwick or North Derbyshire, actually have an appeals process. In terms of the ways, then there would always, of course, be an individual or an organisational reference to the law, perhaps.
The next question comes from the MP Ruth George, and the question is, so Ruth has obviously met with one of our members here because it starts, I thank the Chief Officer for agreeing to meet me at Cavendish Hospital in August. I ask that he visits Spencer and Fenton wards with me and also New Home Hospital, where many High Peak residents worked or are treated, to see for himself the outstanding and cost-effective care provided.
Again, thank you, Ruth. Yes, absolutely. I did meet Ruth, and I committed to meet Ruth and do so in her constituency to talk about a breadth of issues, and I'd be delighted to meet you at the Cavendish and to visit the wards as you describe.
That's me again, folks, for the next question from Councillor Martin Burfoot, District Councillor, All Saints Ward at Matlock. It's a long question, folks, so please bear with me. Can the real purpose of this lengthy consultation exercise be explained if rumours are confirmed at tonight's meeting that the overwhelming views of the public opposed to the CCG's proposals to close New Home Hospital and a ward at the Whitworth have been completely ignored? Is Councillor Burfoot right to suggest that the consultation process was purely a means of ticking boxes for the government, which means that public cynicism towards the North Derbyshire CCG is well placed? This view is reinforced by the CCG's failure to pay heed to local GP practices' concern about the impact of increased patient numbers, which will inevitably result from the excessive new housing allocations proposed in the emerging Derbyshire Dales local plan. And finally, what is the cost of this consultation exercise?
Okay, thanks, Gary. As you say, there's probably about 5 questions within that. So, first of all, the real purpose of the consultation was to hear from as many people as we possibly could. And what we actually got fed back from the University of East Anglia, who did the analysis of all the consultation responses, is it's the largest single consultation response they've ever come across, and they've done many. So we had 1,200 people turn up at 18 public meetings. We had about 6,000 consultation responses. So that was the purpose of the consultation. In terms of, has this made any difference, I guess, let's listen to Clive's presentation in a short while about how we've considered the responses and what's happened on the back of that, so you'll have the opportunity to see that. In terms of the cost, I don't have the figures to hand, but as we said at the start, as Ben said, within 20 days we will give you that information. That isn't a problem at all.
Okay, so the next question was from Sue Tomlinson. And the question goes like this. Will you guarantee that your decisions about the implementation of better care closer to home will not result in treatment and follow-up care that's currently provided by the NHS slipping into treatment and follow-up care that patients will feel obliged to pay for? For example, by increasing the threshold at which the local NHS should begin or continue to treat a chronic condition.
I'd like to respond to that question. Thank you, Jill and Sue. Yes, we can guarantee that if proposals are agreed, yes, we can agree that if the proposals are agreed, there'll be no increase in threshold at which the local NHS fund will fund treatment of chronic conditions. The new services that are proposed will be put in place will continue to be free at the point of delivery. And the services that are being proposed would be aimed at providing care previously provided in community hospitals, which would only ever have been at most for 2 weeks duration.
It's me again, folks. This question is from Brendan McGrath, and it goes like this. Assuming that the final business plan is accepted, what happens then? As the plan is a major change to health services for the area, shouldn't it be submitted to the Joint Health Scrutinising Committee to ensure that the local community needs are addressed before implementation?
Yeah, the plans have been presented to the Derbyshire County Council Improvement and Scrutiny Committee. Scrutiny Committee have received regular briefings from the programme over the last 4 years. The committee have offered us some valuable advice before we went out to consultation about how to conduct a consultation, and provided us with the advice as we've gone throughout the process. We'll continue to work closely with the committee and more broadly with colleagues and cabinet members in Derbyshire County Council if we move forward into implementation.
Thank you. So this next question was submitted on behalf of the chair of the Buxton Action Group. It's Keith Horncastle, and I believe this question was agreed by members of that group. And it is, has the CCG considered the adoption of the Western Hub model sent in response to the consultation? And are the members aware of the adverse consequences for the dementia care pathway in Buxton and High Peak if Spencer Ward were to close? Where would patients formerly admitted to Spencer Ward have to go, bearing in mind the importance of familiar faces, familiar places principle for those patients?
Thank you, and thank you to Mr Horncastle. Just for those who can't see, I'll just introduce myself again. I'm Debbie Austin, I'm a GP in the High Peak. Yes, the CCG's definitely considered the Western Hub proposal in detail, and actually we'll talk through that in this evening's presentation, which is going to be delivered tonight, so for the purposes of the governing body's meeting for us to think about. Our proposals as they currently stand would mean that a very small amount of patients may have to travel further, so from in the High Peak, Buxton and the High Peak, to, in the proposals, Walton Centre of Excellence. But if the proposals because the proposals allow for the development of a dementia rapid response team, which is much different from what we have currently, the actual number of patients requiring hospitalisation would be very small indeed, and most people would be able to be cared for in their own home, and therefore travelling would actually be reduced on the whole. And this supports the familiar faces, familiar places principle. The clinical evidence suggests that we should be moving towards more community-based teams, and the proposals as they stand would allow us to do that.
That's me again, folks. A question from Stephen Walker. What will be the sequence and timetable of closures of the wards, and has staff retention during this period been considered?
Okay. A decision won't be made until later tonight. So we haven't finalised the sequence and timetable. The business case sets out an overall timeline that would see the changes introduced over 4 years. If the proposals are agreed tonight, we'll need to work with provider organisations to agree a detailed implementation plan, which would be developed and shared with staff. We really value the staff that work across North Derbyshire. In fact, they've been brilliant, and it's not been easy with this last year of uncertainty that they've had with this consultation process, and we recognise that. We want a key principle for how we implement any agreement to the proposals tonight is that we want to retain, retrain and redeploy staff whenever possible. We need to hang on to every single member of staff that we've got currently working into the service and to have them working in the new model of care should the proposals be agreed. So we're going to be aiming to work with colleagues in the provider organisations to ensure that workforce changes are coordinated across the system, to ensure fair and equitable opportunities for all staff. And there's a very real commitment to involve and engage staff in the implementation of these plans.
Thank you very much, Gareth, and thank you, everyone. Thank you, particularly Gary and Jill, for asking those questions. As we say, that is just a selection of an extensive number of questions we received. We will be posting the answers to all of those on the website in 20 days' time, sooner if we can get them on. We'll try and get the answers we've provided tonight on as quickly as we can, and then we'll provide subsequent answers in due course. I think it's worth just reiterating that last question and that last answer provided in terms of the current services. I think it's really important in terms of the proposals considered that this is in no way a reflection on the quality of care currently provided on the wards and in the units that we've got across North Derbyshire. I think that the staff and everyone around this table acknowledge the staff provide the most fantastic care to people. And this process never called that into question. I think it was one of the things that we often struggled to get across during the consultation period last year. But I think it is also worth taking the opportunity now to thank all of those staff for the fantastic effort they have continued to put in and the support they've continued to provide to the patients they've been caring for over the course of the last 12 months. And I suppose it is worth apologising at this point on behalf of both governing bodies that it has taken so long to come back to you with a response. As we say, that's because actually the consultation got such a fantastic response from you, the general public, that it took an awfully long time to work through all of those considerations to be able to assure you that they were given due consideration. So that's where we'd like to move on to next this evening. So I'd like to ask, there's a hand up there from a lady. As I say, I'd just like to reiterate, unfortunately, this is a meeting in public rather than a public meeting. So please bear with us. I'm afraid we need to conduct our business if we could this evening. So I do apologise for that. Some of us will be available at the end of the meeting, perhaps to have a bit of a conversation with anybody who wants to do that. So at this point in the evening, I'm going to ask perhaps Steve and Andy just to introduce Clive and this evening's presentation.
Thanks, Ben. Just before I introduce Clive, who's going to speak on behalf of a wider consultation team that covers a number of organisations, I just want to do a couple of reminders that the proposals that we went out to consult on and that you're going to hear from Clive on in a short while have been sanctioned by leading professionals across the whole of the East Midlands, consultants, GPs, nurses, and importantly, have been developed and iterated through local clinicians, not just in North Derbyshire, but based on experience in Southern Derbyshire as well, with dementia rapid response teams that are actually working in practice and supporting people to be safer, independent and close to home as possible. And I think it's just really important that we take the opportunity to make that clear. What Clive's going to do is talk about the process of consultation, the process of reviewing the consultation outputs, the responses to the consultation, and the proposals that will be put forward to the governing body. So, over to you, Clive.
Thank you. I am Mike. Yes, I know where the light is. I'm just looking for the switch. Thank you. Okay, thank you very much. As Andy said, my name is Clive Newman. I'm Director of Transformation for Hardwick CCG, and we'll talk through this process for both CCGs, to both CCGs. The aim of my presentation is to set out the proposals and how we developed the proposals, to describe the consultation process itself, what people said, and how we processed those comments, and finally to set out our response and what that means for the consultation business case. I think it's worth just briefly explaining how we started. It's been an extended process, and we started with three broad principles. We wanted to change our system to work out how best to keep people in North Derbyshire safe and healthy, at home and independent. They were our guiding principles at the start, and they have remained our guiding principles. I'm going to talk briefly about how we developed the plan, which we did over 18 months from October 2014. We took a collaborative approach, so this wasn't simply the CCG or a small group, but it was an extended group involving all health and social care commissioners and providers. We also had used lay reference groups across both CCGs. We began, as I've just said, by developing principles and criteria to agree a model of care, which you can think of as the what we were trying to do and why we were trying to do it. We then worked with local groups, including staff and members of the public, to develop long lists of options as to how and where care should be delivered, and then to shortlist those options. We analysed each option on a range of criteria. So we looked at clinical quality, activity, travel time and cost, workforce, estate, strategic fit, and we developed a set of criteria. So we were looking at the evidence base, access, affordability, effectiveness, against which to judge the shortlist. We asked then a large group, in this room in fact, a large group came together and we asked them to review the outcome of all of those and all of the options, to evaluate each option against that criteria. And that allowed us to develop a final set of options. They then formed the proposals that form within the pre-consultation business case. We then went out, as you know, to consultation from the end of June last year to October last year, and followed that with a month's worth of a month-long clarification process. And this is a diagram that just explains diagrammatically how we developed those. And as you can see, it was quite a complex process. It was overseen by a number of clinical groups, including a clinical professional reference group, which is an internal group. And it was also assessed by an external group, a clinical senate, which is a group of senior clinicians, doctors and nurses and other clinicians from within the East Midlands. And they signed off our model of care as being clinically valid and appropriate. So you probably already know this, but for completeness, I'll just explain briefly the proposals. Oh, I think there's some animation on this. So I'll flick through the animation. What we're saying is, in our proposals, we're proposing to develop 3 new tiers of service. Community integrated care teams, so these are large groups of staff who work in local communities, therapists, social workers, and other professional staff, nurses, who work within our local teams. They'll provide care for people in their own homes and care for people coming out of hospital. As well as that, we're proposing to establish, at the other end of the spectrum, specialist rehabilitation beds close to or in hospital, and there'll be bedded units. And we're proposing also to develop beds with care in each local community. If we do that, we feel that that tiered approach will mean that we no longer need the beds that we currently have in community hospitals. Similarly, this is for older people's mental health. We're proposing, as has already been mentioned today, a new community dementia rapid response team, which is a community-based intervention for people with severe dementia. It provides a response within 6 hours, so a same-day response, and a level of service that runs to up to 8 weeks. And it's designed to provide that care in individuals' own homes. We will also, as we've already said, provide a dementia centre, a bedded care centre at Walton, and we'll provide community dementia services. So these are the local day services within our local communities. If we do all of that, we feel we will no longer need the dementia beds at the Cavendish or New Home hospitals or the day unit services in the community hospitals. If all this happens, we think we will no longer need then the Bolsover or New Home hospital buildings, so we would propose to close them and release staff to work in the new services. This is another diagram that tries to explain that. So what we're effectively saying is currently, or at the point when we put the business case together, we had 100 beds across 5 community hospitals. We estimated, plus another 25 specialist community beds provided by Derbyshire County Council and other providers. We estimated that if we did nothing, the demand for those services would grow and the number of beds needed over 5 years would be 151. Our proposal, instead of all of those beds, is to develop community teams, what we call there the Care at Home service, which will provide a service which will be equivalent of 75 beds, so a service to about 1,700 people. We will develop 44 local beds with care. These are the intermediate care beds, and they will be in each community, in each place. And then we will also develop 32 specialist rehab beds across 2 sites. The majority of them will be linked to the hospital at Chesterfield, with a smaller number at the Cavendish. In terms of older people's mental health and dementia, at the moment we have 50 beds. We have an entirely bedded care model for this cohort of patients. We have 50 beds across 3 sites, Walton, New Home and Cavendish. Our proposal would be to move, and if we do nothing, the demand will rise to 60. Our proposal would be to develop a rapid response team. This is the community-based team that I mentioned, that will provide care for the equivalent of 30 beds and retain 30 beds on a single site in Chesterfield. This slide here just describes those proposals and describes how we presented those proposals in the public consultation, which I'm sure you've read. So we developed effectively, we cut them into 3 proposals. The first proposal talks about forming the integrated care at home teams, beds with care, moving services out of dementia day units, introducing the rapid response team, and establishing community hubs. The second proposal then goes on to discuss closing the community hospital beds, providing the specialist rehab beds, closing the older persons' mental health community hospital beds, and establishing the service at Walton. And then the third proposal talked about closing Bolsover and New Home community hospitals in total. So, as you are maybe aware, we are obviously legally required to consult, and as Andy's already said, we wish to consult to understand what the public thought about these proposals. Within the legal consultation, we are advised to follow what they call the gunning principles, and you can see them there. Effectively, this means that we need to consult at an appropriate time before the proposals are finalised. We need to give people time, the proposals in enough time to consider the proposals and to allow them and present them in a way that allows for them to be considered intelligently. And the product of all of that, all of the responses we get, must be conscientiously taken into account, which I'll go on to describe. The consultation, there is more information about the consultation process, and we will be showing that on our website as one of the supporting documents. But as we've already said, it was a substantial response to the proposals. We had 35 consultation documents sent out, 18 public events, 20 drop-in sessions, smaller stakeholder meetings. We had over 2,000 surveys returned. We had significant petitions from each of the areas linked to the local hospitals opposing the closures. And as I've already said, we also had extended the consultation by a month to allow for clarification on some of the numbers. These next 3 slides summarise broadly the response to the proposals. These weren't compiled by us, this was compiled independently of us by an independent academic, and the full report is available on the website. Broadly, though, briefly, in terms of the first proposal, there was support for the care at home teams. There was some concern about the beds with care in terms of the quality of care they'd be able to offer. There was disagreement with moving the day unit out of the community hospitals. People broadly agreed with the Dementia Rapid Response team, and they accepted the idea of community hubs. There were themes, and these were themes that underpinned a lot of the responses around quality, concerns around quality, staffing, the use of the hospitals and the beds, costs, management, logistics, location, the impact on carers and on respite care, and particularly from the west of the county, but from many places, concerns around travel, transport and access. In terms of Proposal 2, which, as I've said, was more about closing beds, you will probably not be surprised to know there was broad disagreement with the proposal to close beds in any of the hospitals. People felt generally that the introduction of the specialist rehab beds, the new specialist beds, was a good idea. People were concerned that overall the number of beds proposed was low, and people disagreed with the idea of closing the OPMH beds at the 2 nominated sites. Again, the themes remained largely similar. And finally, the third proposal around closing the hospitals, there was broad disagreement on closing the hospitals. They were considered to be needed by the local communities. And again, the themes were quite similar. Concerns about patient care, around management and timetable, around cost, around the use of the hospitals themselves, and staff and carers. In terms of how we then took all of this information, all of these responses, and considered them, this next section is just going to try and quite briefly describe that process. Effectively, we used 2 groups. We used a smaller multi-agency group of staff to process all of those responses, filter them, and offer a specific response to every issue. We also had a larger group, which we called the Cross-Cutting System Review Group, which was a larger multi-agency group, including clinicians and lay representatives. They reviewed the work of this smaller group, agreed the process, and made the responses that you're going to see tonight. It was quite an elaborate process, which involved 5 steps. So we collated the responses, we categorised, we looked at every individual comment and categorised it. We then responded to those individual comments and decided whether we felt they needed to be taken further or could be responded there. We then, from that, identified a range of key issues, and we explored those key issues in more detail. You'll appreciate we couldn't explore in detail every single response of the thousands and thousands we had, and you'll also appreciate, I'm sure, that a lot of the responses had similar themes, so we attempted to theme them and respond. We then used those responses to review the business case, and then, as you'll see tonight, we prepared a revised business case incorporating those responses. So effectively, we ended up with 3 sets of issues that we felt we needed to know, but didn't necessarily need to take further because we could see that they'd already been considered within the case, or they were relatively small and immaterial to the fundamentals of the case, or they were incorrect. We had another set of issues that were concerning the model itself, so the clinical model and concerns about the clinical model. And then we had a range of issues that were not perhaps directed at the actual clinical model, but were concerned about how that model would be implemented, what sites would be closed potentially, and what services would be put in place. This is a flowchart which demonstrates that. As you can see, we ended up effectively with two broad sets of issues. As I've said, concerns about how the model will be implemented rather than the model itself. We felt these were specifically about implementation. We've noted them all and logged them, and they will be form part of an implementation process. If the model is agreed, they would be part of a risk log that would then be continually looked at as part of the implementation process. The second set of issues were concerned the assumptions underpinning the clinical model itself, or the financial model, and the viability of the model, and these were the ones that we considered in a great deal more detail. So the kinds of implementation issues, I won't go through the whole list, but there were concerns about how we would plan and train to establish the full workforce, how we would retain staff, some of the logistics about how we would actually run the implementation if it were to go forward, what we might do in terms of increased demand, how the governance of that would work, and how it links into our broader plans such as the sustainability and transformation partnership and plan timetable. The key issues that we identified are listed there, and I'll go through them all in detail, so I won't talk about them specifically now, but effectively, as you can see, a chunk of concerns around older people's mental health beds, a real concern that we shouldn't remove the beds from the west of the county, and as has already been mentioned, a concern that we had misunderstood the demand and the need in the west, and that we should look at developing a western hub. Concerns about the other beds, the rehabilitation beds, the beds in the community hospitals, concerns that closing those wards and therefore closing the two hospitals was the wrong model, that we should retain the beds, that we should continue to have a bedded care, primarily a bedded care model. Particular concerns about what became known as the A6 corridor, so the closure of two of beds on Whitworth and Newhome because of transport and access issues. There were also, and more broadly, lots of concerns raised about impact on carers, about the issues about relocating dementia day services, about concerns about how the dementia rapid response team would work, and specifically as it's designed to be an 8 o'clock in the morning to an 8 p.m. service, 7 days a week, what would happen overnight. There was some scepticism about the funding and about our ability to fund this change, and about the fact that we are proposing that we can do that within budget and managing increased demand. And there was concern that this would mean a shift from NHS to social care. We began, before we looked at those specific issues, by asking the cross-cutting system review, which, as I said, was a broader multi-agency group, including clinicians. Should we make fundamental changes to the model? So we asked them two key questions. One, is the clinical model, which, as I've said, would see a reduction in beds, an increase in community teams, and a move from beds in community hospitals to beds with care and specialist rehabilitation beds and integrated care teams, and a model that would see a reduction in OPMH, older people's mental health, beds, and a move to more community-based interventions and a community team. Was that clinical model unproven? Was it still correct? Was it still fundamentally the right type of model? And then linked to that, if that model is correct, are our specific proposals about where and how we would site services in terms of the number and site of beds, etc., still the best options of all of the options that we considered? The cross-cutting system review considered the consultation response, considered again the business case, and looked again at all of the options that we had considered the first time round. They felt fundamentally that the clinical model was still correct, that was still the right model, and that whilst recognising that the proposed changes would not be perfect for everyone, and it's clear that they won't, like any change, it won't be ideal for everybody, fundamentally, they felt that for the populations of North Derbyshire CCG and Hardwick CCG as a whole, there would still be the best clinical model. They would provide the best clinically and the fairest way to deliver the new model of care, and they would be financially viable. Going into the individual key issues, this section briefly talks about the feedback, our response to that feedback, and our changes, therefore, our proposed changes to the initial recommendations. So this slide, you probably can't see all the detail, but it is a summary of what's already been in the public domain, describes in a summary the idea of the Western Hub, which effectively would entail retaining the beds on the Spencer wards as they are for respite and assessment and emergency crisis submission. Also, alongside, developing the Dementia Rapid Response Team and putting those two things together to develop a Western Hub, a Western Centre of Excellence. So that would be a DRRT, training centre, inpatient facilities, and the idea would be that the staff would rotate through those two different services. There was also talk about the opportunity to merge the older people's mental health wards and the general wards. That was something several people suggested might happen. And there was obviously a lot of this was arising from significant concern about transport problems for some of the patients. We looked at this in detail. We looked to cost some of these up and to look at the clinical model behind this. Effectively, the clinicians were still remained to say they felt that the clinical model of a single centre with a dementia rapid response team was a more effective model. Locating all the services in a single site would be a more resilient way to staff. It would allow you to deliver over time a sustainable and high quality service. The dementia rapid response team would, because you'll be able to provide more care for people in their own homes, would reduce the number of beds you would need, and that would substantially decrease the number of beds in the Western Hub. And the clinicians and the cross-cutting system review felt that this would make the idea of a relatively or a very small number of beds in a single site would be clinically difficult to sustain and financially difficult to sustain. So financially, the cost would be approximately £860,000, which, to put it into context, is a third of the total cost for the dementia rapid response team across the whole north of the county. So it would be an expensive model. And of course, we're recognising that some people have to travel further. Overall, though, the modelling that we'd done about travel suggested that 60% of the people in 60% of the areas, people would have to travel less far. Some people will have to travel further. Some people... in the area, so in 6% of the areas, people would have to travel less far. Because you're actually able to develop this dementia rapid response team, which would be providing people in their own home. Obviously, if you're getting care in your own home, you don't have to travel anywhere. The key thing, I think, as well, the clinicians were saying is that the best place for people with dementia to be treated is in the place that they're most familiar with, which is in the place they call home or their own home. And this dementia rapid response team would be able to deliver that. Ultimately, we're proposing to confirm the existing proposal for a single OPMH bedded care model, which means that following consultation, we still continue to support proposals to develop the rapid response team together with the bedded unit in Chesterfield, and wouldn't support the development of a Western hub. The other issue raised was about respite care in Buxton. Spencer Ward in Buxton has 2 respite care beds. 2 of those 10 beds are respite care beds. In 2014-15, there were 16 people, 16 recipients who received overall 91 weeks of respite care. The cost of this is estimated, if you were to continue to provide it in the NHS, it would be about £280,000 or £150,000 potentially in a care home. Now, this respite care is not provided anywhere else in Derbyshire. This is not something that the NHS funds normally, commissions normally. It's not something the NHS is responsible for. However, we have provided it, commissioned it, and provided it in Buxton in those 2 beds. There is an argument that this is inequitous and that therefore it is unfair to other places and other patients that we're investing only in Buxton and nowhere else. However, the view from the group was that the plans don't include an alternative at the moment, and therefore contravene the key principle of our plans, which was that we wouldn't take a service away until we were confident that we had a reasonable alternative in place. So the recommendation would be that we would leave the respite care to be commissioned for the people who currently receive it, but that it's phased out over time and new patients wouldn't be accepted into this particular service, and they would be treated exactly as all the other patients in North Derbyshire currently are. So the recommendation there is that we continue to commission for those currently receiving that provision. Another issue which was highlighted as part of the consultation was around functional mental illness. So dementia care is an organic illness. There are other functional mental illnesses such as acute schizophrenia. This ward has in the past taken those kinds of patients alongside patients with dementia. And there was a proposal that we maintain that service. Now, we looked at the numbers of people. The numbers had been high 2 or 3 years ago. They'd dropped significantly with a change in clinical practice, so that in 11 months, only 7 patients had been admitted with these kinds of conditions. As I say, it's low and it's declined significantly. Clinically, it's not ideal to put people with dementia and people with functional mental illness on the same ward. And it's certainly, another suggestion was to combine the general mental health and the general health wards, the Spencer and Fenton wards together. And clinically, that was considered to be not acceptable at all. And our clinician said that wouldn't be in line with best practice. And certainly the Care Quality Commission, our regulators, wouldn't allow that. So that was ruled out. The recommendation, therefore, that we do commission services for functional mental illness from local providers, and the recommendation would be we would extend that, we would provide additional commissioning. We would commission more services from local providers for those functional patients, functional mental illness patients, and phase out patients being admitted to the Spencer ward with these kinds of conditions. So as that says. Moving on from older people's mental health to the rehabilitation beds, there was, as I've already said, significant concern around removing community hospital beds and closing wards in the hospitals, and specific concern about all 3 hospitals, and also the idea that we had a particular issue with beds on the A6 corridor, i.e. at Whitworth, the new home, because of transport. Again, specialist beds on the 2 sites, at the Cavendish and at the Royal, plus beds with care, plus the integrated care teams, was was seen by us as part of this as remaining the best clinical model for the majority of people in North Derbyshire in terms of it being consistent with clinical advice and best practice, it being balancing the access to services against affordability, and allowing us to retain and keep a resilient workforce. We therefore argue that propose that the decision to close the hospitals at Newham and Bolsover remains correct. The other services in the hospitals could be re-provided elsewhere within the local community, we believe. We think with the development of local beds with care in more communities, overall, we will have a fairer model for the majority of people in North Derbyshire. We think the idea of retaining the hospitals without these beds is unaffordable. It would cost a significant amount of money. I think for Bolsover, the cost of running the service of the Bolsover Hospital without these services would be something in the line of over £750,000 a year, which we think could be reinvested in services, in teams. And for Newham, the cost, I think, is about £600,000. And again, we think that would be better reinvested in services. The hospitals themselves, without these services, would be only a fraction of the hospital site will be used for clinical services. So I think for Bolsover, the amount of the space used for clinical services reduces to under 10%. And for Newham, it's certainly under 20%, I believe. So it's a relatively, you've got a big site that's expensive to run with a relatively small percentage of it being used for clinical services, and that has a knock-on cost. So you're spending between £50 and £350 before you even, on every appointment, before you even, just as an overhead. We think it is to correct. The other argument that was raised was about putting the specialist rehab beds elsewhere. So there was a suggestion that they could go to the Ochre ward. This was discussed at length. The concern where our concern with that would mean is that would mean most of these patients are at the acute hospital. They're what we call step down, so they're coming out of the acute hospital into these specialist rehab beds before they go home. If they're coming out of the acute hospital, the best place for the specialist rehab beds is near the acute hospital, so that transfer is small. It's a small transfer, it's a short one, and so that the services that these people might need, because they're still quite poorly, they're close to. So if they then need to go back to the hospital for anything, they're relatively close to that. So we felt it reasonable to locate them near to most of the beds near to the Royal Hospital, where most of these patients will start from in this part of their journey. Felt the concern about putting the services in, say, Ochre ward was that patients would need to come all the way from the Royal. Most of the patients would come all the way from the Royal into the Ochre ward. Most of the patients in North Derbyshire don't live near the Ochre ward. In fact, most of our populations live closer to Chesterfield Royal, so it would mean for the majority of people they would not only have to travel further to get this specialist rehab, but they would not even have to, or if they had a problem, they would need to be transferred back to the hospital, which would be an unnecessary transfer. The other key issue, of course, is that splitting or retaining multiple sites, as I've said, retaining those hospitals is expensive. Splitting into 3 or more specialist sites across North Derbyshire would mean that we split our staff, and it's quite a limited number of people, and it would cost an additional, more than £800,000 per year to run. So, again, we're proposing to confirm the model of specialist rehabilitation bedded care in Chesterfield Royal and at Cavendish as the best balanced model, and we continue with the proposals for specialist rehab beds, the beds with care in every local community, and expanded integrated care teams. And once we have those established, we would continue to propose that we would close the beds in the community hospitals, and then ultimately the Newham and Bolsover hospitals themselves. Moving on to the other key issues, we asked the cross-cutting system review to look at each of these issues, and we also asked them to consider whether they felt there was sufficient assurance already in place, or we could put sufficient assurance in to make sure that none of these issues was a deal breaker, that they weren't going to be, but delivering care to the right standard wasn't going to be so difficult as to make the case impossible to deliver. And I'll go through those issues individually. So, impact on carers, including travel. There was significant concern about the impact on carers, and particularly about travel time. As I've already said, we felt that the needs, that actually it's absolutely recognised that some people will have to travel further, but we believe that the majority of people will be able to get care closer to home, because we won't be reliant on beds in fixed locations, and instead we'll have more community care teams providing care in people's own homes, and more beds with care in the local communities. We definitely, as an implementation issue, need to consider the issue of people travelling across from Buxton in the west over to Walton. As I've said, we think the numbers of people having to travel will be relatively small, because we're talking about particularly the patients who are carers and loved ones of the patients in those 10 OPMH beds having to go across to Waltham. So it's a relatively small number of beds. Some of those people will be cared for by the Dementia Rapid Response Team. But for those who do have to go across, we do need to consider how we can help those people. There are a number of existing ways that people can travel for free or at reduced charge over the hospitals, including the healthcare travel cost schemes, the non-emergency patient transport services, and the voluntary sector and community travel schemes. We will obviously need to use those, and we will need, throughout the implementation, to monitor the impact and look and make sure that these provide sufficient coverage to allow people to travel over. We must ensure, in terms of the implementation, that carers are central to the planning. We need to monitor the demand for these schemes. Potentially, we may need to increase investment in these door-to-door travel schemes if demand increases. We will need to consider supporting carers, and we'll need to ensure the inpatient facilities where people do have to travel have flexible visiting times. So we have got a lot of issues to address as part of the implementation. But, as I said, fundamentally, we believe that most people will have to travel less far. In terms of beds with care, so these were concerns about, as I've said, about capacity and location. One of the concerns was, understandably, where are the beds with care exactly going to be? How will you staff them? How will you guarantee quality? Will you be using private homes? In which case will people have to pay? Will they not just result in more people being stuck in the hospital? Again, we considered all of those. We looked again to see, we haven't, and we didn't obviously in our consultation set out exactly where these beds will be. But we did look across the patch to say, do we have beds with care model already working? And if so, how does it work? And we felt, yes, there were areas where it was already working well. We didn't feel there were any areas where it was going to be impossible to establish these beds with care. However, of course, we won't, until we are clear that we can establish those beds with care, we won't be closing the local community hospital beds. We will commission those beds with care to Derbyshire County Council and NHS standards, whether we commission them from private providers or whether they're provided by statutory services. Staffing is a challenge. It will always be a challenge. It would be a challenge within the community hospitals or within these beds of care. Our integrated care teams, which we're proposing, will reach in to provide support and care at these beds with care. And we have got plans within our implementation, within the business case, as to how we're going to develop the staff, retain and redeploy and increase the number of staff to provide that care. We feel that the beds with care being local in every community. We've got potentially 44 beds with care across every community, more equally distributed than current community hospital beds. It will give patients more options. They will be closer generally than, for most people, than the community hospital beds are. And the idea of having specialist rehab, 3 options where previously we only had 1, so specialist rehab, beds with care, and these integrated care teams in the community give staff in the acute trusts more options, not less. And the acute trust clinicians concurred with this. In fact, you'll remember they were party to developing these proposals in the first place. Again, a concern about dementia day services. So the concern, as I've already mentioned, that dementia day care, which is currently provided in the hospital service, shouldn't be re-provided in the local communities, concerned that these services would be lost, concerned that access would be poorer. We actually would argue, and we looked at this again, that for many people, day hospitals are not ideal places for people with dementia. The evidence suggests, again, people with dementia need to be in places that are familiar to them. Hospitals are not always familiar places, and not usually familiar places for people with dementia. They're not brilliantly distributed equally across the county, so people do have to travel. Whilst it's ideal, of course, if you live next to the day hospital, if you don't, you will have to travel, and we are seeing people have to travel. Because they're provided in a single setting, there's not much flexibility in terms of being able to offer different settings and different group sizes. The clinicians tell us that some people don't like to go into a big group. They're concerned that they'll be in with people who've got more severe dementia than they have, and some people with dementia just don't like to be in that setting. In fact, some of the services that we try to currently deliver out of dementia day hospitals are actually poorly attended. So we have relatively low take-up of one of our key services, Living Well with Dementia, and the teams propose that the changes would help us to improve access to that service, take it out of those settings, and potentially triple the numbers of people accessing the service from 200 now or in the baseline year to 600 in the future. So we're hoping that we'll be able to offer a greater range. Talking to the clinical teams, they already provide some of these services in the community. They will be responsible for finding sites for the new services. Again, they don't have to be provided in a hospital setting. They are confident they will be able to provide the sites, and again, we won't be closing the hospitals, the day units, until we have these sites.
It's obviously a really important presentation, but I am just conscious of time, so if we can make sure, I think we need to allow enough time to give the presentation, because there's obviously some important information in there, but if we're just conscious of time.
Okay.
Thank you.
I will try and speed up. In terms of funding, we looked at the funding, this again is in the detail, we looked at the business case, again looked at the funding behind the business case. Fundamentally, we think the service will allow us to provide services for more people within our existing funding and allow us to work within our budget over time. So we still feel that the service model, we didn't hear anything in the consultation to suggest that the detailed financial modelling that we did to develop the case was incorrect. We feel that that is correct, and that therefore that the service will be affordable. In terms of impact on social care, again, the business case is clear, and we can point to examples where we've clearly identified the need to transfer money, and we've quantified the money that will be transferred from the NHS to adult social care to develop this model. So we feel overall that we have got appropriate mitigation. We've considered all these issues appropriately, and none of them would be deal breakers. We would still be able to deliver the proposals. I'll be quick about this. Since April of this year, there's been a new test for service reconfiguration, which makes a condition of any service that you don't decommission a service until you have commissioned the alternative. As I've already said, it's a key principle. We've said that from the start, and it remains a key principle, so we feel that we have addressed that. In terms of implementation, as I've said as well, a lot of the issues raised, we feel, are very sensible, and we will need to address them as we implement, and we need to be careful about how we do that. And we'll need to do that listening to staff and listening to the public, and in as transparent a way as possible. So we have developed here a set of implementation principles, we're reasserting a set of implementation principles and an approach that would see us implementing carefully and transparently. There is a slide here about how we feel we've accorded with equality and due regard to the health inequality and quality assessments, which is something we have to do, and that has changed some of our recommendations in terms of our recommendations about how we implement, which I'll talk about in a minute. Before I just finalise with the final set of recommendations, I hope this presentation has summarised the process, the response, how we considered those response, the issues raised, our response to those issues, and the changes to the business case in light of that. So what I'll just talk about then is the final proposals. So you will have seen, if you've seen the papers, the final proposals. They're also on the cover sheets, and we will talk about these in more detail, obviously, as part of the discussion. Effectively, the proposals remain as they were. We are also, though, proposing, and those in italic are the new proposals, that we continue to commission respite care from Spencer for them patients currently receiving the service, that we would phase out the commissioning of functional mental illness at the Cavendish, admitting to Stepping Hill or another alternative provider, that the OPMH proposals remain as they were. The community-bedded care, we're proposing to, as I've said, increase the number of local intermediate care beds, these beds with care, develop an integrated care service, develop specialist rehab beds, and close, if that is all successful, close the community hospitals. In terms of other services, if this is all successful, as I say, the proposal would be to close the hospital services, the hospital sites at Bolsover and Newhome over time, and to re-provide those within local sites to the community. Obviously, that is subject to the provider boards who own those assets. In terms of implementation, as I said, we have strengthened the implementation recommendations to ensure that the implementation principles within the business case are upheld, that we establish effective governance, that we undertake or continue to undertake equality analysis and quality impact assessment, which we have done, which we will continue to do, that we develop and ensure a comprehensive communication plan with patients, staff, carers, wider public, and that we ensure effective communication with those groups. I think this summarises the decisions for the governing body this evening. The first 3 points reference the proposal, the process itself. So I think they're summarised. They cover the first document that the governing bodies are going to look at, which is agree the process, agree our response to the feedback that we got, and note that response and those responses and that impact on those proposals. And then finally, agreeing the business case and agreeing the proposals set out in that final business case. That's the end. Sorry about overrunning.
Okay, thank you. Thank you to Clive and thank you to the team who worked behind Clive, on behalf of both governing bodies, I think what we've seen is that a very large amount of information has been distilled into some comprehensive slides that will help decision making. I guess as an accountable officer, and recognising my pledge to the public when I came into this process halfway through, when I joined the clinical commissioning group, when I came in halfway through the consultation process, I was always clear that what I needed to see was that there was a robust process, and that at the point that decisions were taken, they were taken off the back of a robust process. And in my understanding of what Clive, you've just presented for us, what I'm seeing is that proposals were developed off the back of very clearly agreed principles up front, clinical evidence and input throughout, and particularly thinking of external support for the initial model that was then taken to consultation, that the gunning principles were followed in terms of that engagement, and that there was the external support to make sure that we weren't selective in the way that we received feedback. And I think it is important that we do, as governing bodies, respect that what you presented to us just there, Clive, was very extensive feedback, and we've seen over the course of the last 3 or 4 months a very, very significant piece of work undertaken to synthesize and then address all of those issues. I guess for me then, I am left at this point to hand back to the chair with our thanks for that, but perhaps just reprising in my own sense two points that you raised up there. The question, is the clinical model still right, and are our proposals around the location, the beds, the site still the best options? And I think the language you were using there was that whilst not perfect for everyone, they were still the best clinically and fairest way to deliver the new model of care. I think that's the point for handing back for the next phase of this consideration.
Thank you, Steve. Thank you, Clive, and thank you, Andy, for introducing it. Right, at this point, we've got an opportunity for governing body members to ask questions, seek any clarification, or indeed to make any points they wish to raise at this point. So I'm going to look around the room and ask for any hands, any points, any questions. Somebody must have something. Jane and then Ian on the North Derbyshire side.
Thank you, Ben. I'd just like to say that recognising that these services that we are proposing are a radical change from services that patients and carers value, I'm just interested about how visible quality and safety issues will be through any change process to a whole governing body. I think as the member of the governing body whose prime responsibility in terms of portfolio is quality and safety, recognising Jim also in Hardwick, I think I just want to really be assured that this is not just a numbers game, that this is actually that we will be really able to articulate the quality of services that we are providing. So I guess I'm just seeking that will be visible at the highest level in the organisation, so at the governing body level.
Absolutely, it will. No, yeah, I think you're responsible for doing that and bringing it to the governing body, but I'm absolutely sure the governing body and Jim, on behalf of Hardwick, will ensure that that happens, and the governing bodies will both ensure that you're held to account.
Absolutely, and I think just picking up on Jane's point, I think I'd welcome when we were talking around the implementation process that quality impact assessments will be done at each element of the implementation. And again, I think links back to Jane's point, because there will be a process to bring any adverse impacts back to governing body and through the due governance processes. So welcome that.
And I think one of the things we've also highlighted there, and we come on to again a little bit later on, is the need still to develop the governance processes around implementation if the proposals are supported this evening. So there is quite a lot of work still to be done on making sure that is right, and both governing bodies and the public have the transparency that they need to see that that's being transacted properly. Ian.
Ian Gibbard, North Derbyshire CCG. And Clive, if I could just try and paraphrase some of the things that you've put across in your tremendously detailed presentation, just to make sure that I've understood. And it was three things really. The first is there seems to be a general public understanding of the scale of the ongoing challenge to health services in North Derbyshire created by the demographic changes in population, specifically the increase in older people's mental health issues. That didn't seem to be an area of challenge. There is to some measure of agreement on the current service model needing to change. And I think the extent to which we invest in community services has generally been supported. I think there is a view that we need to do that in line with best practice and also in line with NICE guidelines and so on. Where there is deep suspicion is about the potential gaps that could still arise in the service model, specifically the impact on patients and carers in more isolated situations as a consequence of closing beds and some of the proposals you put up there. That's what I've heard generally from the consultation. My question really is, in terms of dementia rapid response teams, that is not a new proposal. It may be new to North Derbyshire. And I wonder if there's anything, the experience that Southern Derbyshire have had, that you could draw on just to give confidence in putting this across as a proposal, and specifically the experience of patients and carers in those isolated areas in relation to out-of-hours services. What can you give us on that?
So with that specific response, we did ask the Southern Derbyshire team to identify what their experience, because that was a significant concern. They reported that effectively they were saying that by providing proactive care during the day in that 12-hour slot, you were actually reducing significantly the demand overnight because you were getting people to a point where they were more comfortable to stay. Of course, I would also say we haven't, the out-of-hours service, people are still able, the same out-of-hours service still exists. We haven't reduced or diminished that. So the same access to service exists. They reported that of the people that had to be admitted in their 8 p.m. to 8 a.m., the vast majority, all but one, were admitted under a section. And the section had actually been undertaken during the day, but because the section is a complex process, it hadn't taken effect until that out-of-hours period, that post 8 o'clock in the evening. So that meant that it had been classed as an out-of-hours admission. As I say, they report, and the feedback we've had from the patients that they sent me today, most up-to-date feedback, is very positive from patients about the level of, and the carers, about the level of service that they've received and the service they've had from that team and the support that they've had.
Ruth Cooper, GP. I'd just like to add to that from my point of view as a clinician working in these communities, and an observation. I've been in practice now for nearly 25 years, and what often happens is that we actually watch these people deteriorate. We anticipate their conditions are deteriorating, but at times it's very difficult to get the right support, the expert support that we require from the older people's mental health team. And so we do need to shift these resources. What we watch is people deteriorate, we watch families struggling, trying to look after these patients in their homes, and eventually the only option, because they've deteriorated to such a degree, is that they have to be admitted to hospital. And this is an opportunity for us to invest in more proactive care, to support those families at an earlier stage with more expert help, so that actually we can prevent this happening and that they do actually require a hospital bed.
Isabel, then Debbie, and Steve, please.
Yeah, Isabella Stone, lay member. I just wanted to ask you were talking earlier, Ben, about the governance process, that we need to put in place assuming that, or if these proposals go forward. But the concern I have is about the engagement process, and, you know, it's particularly engagement with carers, because in the presentation, people had obviously raised issues about carers being centrally involved in the design of services, and yet in Clive's presentation, which was an excellent presentation, I thought, there was much more, there was a focus very much on transport issues, and it's clear that it's not only transport issues that carers are concerned about. So it's just really to ask, you know, will there be an engagement plan visible to people early on in the implementation process, and will there be particular bits of that plan that spell out how we're going to engage with carers?
Clive, I think the post-consultation business case talks about an implementation plan in terms of...
Yeah, I think you're right, and I think you're absolutely right that the way that I perhaps developed that slide didn't reflect... The issues for carers weren't just about travel. People were very anxious that they would get less support, less respite care than they currently do. And this wasn't just the respite beds at Spencer. This was also, for example, the dementia day service. People were saying without these day services, will we get less support? So I think, firstly, in terms of implementation, we need to establish carers at the heart of that, and the idea would be that as we're developing local models of care, we have multi-agency groups, including staff and carers, to develop the plans and what those plans will actually mean in local communities. There, as we've already said, there'll be a governance process. We'll see, you know, the kind of normal, boring but safe, if you like, NHS governance apply, NHS and social care governance apply. So a programme team, a programme board, and lay representation on those groups, so that there is some oversight and some clarity. And we've said, as we develop these plans, it's really critical that local people are involved and local staff, and we need to be transparent about them. So we haven't developed them fully because proposals aren't yet agreed, but the idea would be for things like, you know, open sessions, open meetings where people can come and listen to local plans and come and help develop those plans. So I think you're absolutely right. That is a big issue. I would say that we don't believe that we absolutely understand that respite care and care for carers is critical. I think we might say that the system as a whole often doesn't do enough. We don't believe our plans make this situation worse, but we do feel like there is more we can do, and that we do need to. It was a clear signal back from the public, and we do need to pick this up during the implementation.
Debbie?
Thank you, Ben. Debbie Austin from the High Peak. A couple of things, really. One is actually also about carers, which we all recognised as a concern for all of us as we were going through the proposals, and clearly it's something that everybody else has concerns about. I'm specifically referencing some things that were in the papers about all the opportunities that people have for access to travel and things, a lot of which I actually wasn't aware of, so that was really helpful. But I'm specific now thinking about the High Peak residents and the very small number that will regrettably have to go to Waltham if we agree to the proposals. And it was occurring to me that we are aware that obviously taking people out of their house is a very bad thing to do unless it's absolutely necessary. And we talk about familiar faces as well as familiar places. Familiar faces is incredibly important. And I was just thinking, even if people have got transport to and from Walton from my neck of the woods, they're not going to be able to spend very long with their relatives there. And it occurred to me as part of the implementation whether, and this, you know, this is where we involve carers and things in these decisions, is there would be some sort of facility in Walton where people could actually stay over. And because carers, relatives still are their carers and still may want to carry on being their carers. They may not want to. They may have got so ill with it that they actually need some respite themselves, but they might still want to. And it'd be really nice to have some options available there, I think. So I've got one other little thing. Shall I just stop there, Clive, and let you answer that one first?
Well, only in as much to say that I think that's an excellent idea, and certainly we'd in the response we've talked about extending and making sure that we have flexible ways to support, like flexible opening hours, and make sure people when they do get there can stay there as long as they like. But you're absolutely right to say it's a long journey over and back. So if we can establish a way that people can stay, that would be an excellent idea, and I think it would be definitely something that we would want to pick up as we develop the proposals.
And then the only other thing I wanted to say really was the clinical aspects of this, and just to reiterate really what Ruth had said, which is, and again, this is working in a rural area. As a GP, and a lot of my colleagues often want to be able to keep people at home, but we can't because we haven't got the resources, the facilities, or the staff working in the community to help us to do that. And we often feel that we fail our population by then having to send them into hospital because we've got no other option. And actually, if we are able to implement something like this, I think that it could only be a good thing for all of us, and working in even bigger teams. We've had some meetings with GP colleagues about the potential increase in workload, although we need to discuss this further, obviously, if we go to implementation phase. But actually, I think that because we end up at the moment having to do all sorts of things that actually a bigger team could help us with, I think overall it would be a better situation for GPs as well as the patients. That's the general principle. I feel there's some really good clinical evidence for that.
Steve? Thanks. I guess, Debbie, you've partly sort of moved some way towards answering my question. It's a question to the clinicians in the room, but also to the chief finance officers. And forgive me, I want to go back to that paragraph that you had on the slide, Clive, and that I just quoted earlier on, which is about, is the clinical model still right? And then recognising it's not perfect for everybody, it's still the best clinically and fairest way to deliver the new model of care and be financially viable. So I suppose I'm just kind of asking the clinicians in the room that they're saying, yes, that is right. And equally, I'm asking the chief finance officers that they're saying, yes, that is right.
Yeah, Miles, Mick, do you want to respond to that, please?
Yeah, hi, Miles Scott, Chief Finance Officer at Hardwick CCG. We spent an enormous amount of time going through financial assumptions, making sure that they're robust, making sure that the business case makes financial sense, there is investment, and the investment, it pays off very quickly throughout the life of the project. Should we go to that implementation phase? So I'm absolutely clear that it makes perfect financial sense in that sense, and in actual fact that not doing it starts to become a financial burden that the local health community can't afford in the future.
So I'll reiterate some of the challenges I made in the confidential session. So one thing, and apologies for the public, I'm going to be technical for one moment, but for colleagues in the room, recognising this is neither a commissioner or a provider-driven business case, but the way it was described to me is a systems-level business case. And on that basis, I'm confident that, quote, this business case is affordable within the existing financial resources that is available. Wherever those resources sit, either in the provider or in the commissioning arm of the NHS system within Derbyshire itself. What I would like to say is that the discussion tonight, there's some really hard and difficult decisions we have to make. What I'm hearing is that there is a drive to make the right change for the services, despite what people are saying at the moment. So for me, the need to get into that affordability discussion into some real detail to actually test that challenge doesn't happen now. It happens after the decision, which is only at the outline stage. We have to, again, being technical, move to effectively a full business case stage of implementation. That is when we get into the detail associated with that. So my view is that we are a clinical commissioning board here. We are making a decision primarily at this stage on whether this is the right clinical model. But I would support Miles and the work that the CFOs have done that predates me, that based on what I've seen to date, that this is an affordable model that we should be supporting. But we need to be focusing on, is this the right clinical model at this stage, if that helps members.
And I think just to reiterate from my perspective, Steve, in answer to your question about the clinical model, the other thing to remember is this isn't necessarily a brand new model. This is a journey that we have been on for some time now, and actually Ruth and her practice at Stafford have been leading the way in terms of developing integrated community teams and this new way of working. We know in terms of the units in the community hospitals that the beds have significantly reduced over the years because actually we've managed to reduce the length of stay, we've managed to support people better in the community, and actually what we've seen is a number of beds close already, but we've kept the same number of units up until now. And the difficulty and part of the reason for this consultation is we've reached that sort of crunch point, that breaking point where in terms of the finances, we now need to address the number of units as well as the number of beds in each unit. And that's part of where we're at. But this is a journey we've been on for a long time now. And this is really just about taking the next step on that journey. Sid, I'm conscious you had a query you wanted to raise as well.
Dr. Sudeep Chawla from Wingworth. I had 2 points I was going to make, and my second point was in answer to Steve's question about the clinical aspect of it. I think, as clinicians, I think we're all in agreement in the room that patients do deteriorate very quickly when they're admitted. Patients lose weight. They are at risk of sores, and there are a lot of things where muscle mass is lost, and I have seen it in my own personal patients. I think care at home will allow for holistic views, a physiotherapist and occupational therapist coming in, helping the patients exercise and things. I think the evidence there speaks for itself. The first point I wanted to say, which wasn't related to Steve's point, was that the consultation process has been, I think, quite excellent, and I want to thank Clive for his presentation. I think we can all reassure, I'm pretty reassured that it was independently done and a lot of the issues that were raised have been listened to. But I think whatever the decision is later on this evening, however we vote, if we do vote for implementation, I just beg of the government bodies that we actually don't lose sight of this process from the start, that we actually take it on board even throughout implementation if that is what we do.
Ruth, do you want to come in there as well?
In response to the point you raised, Steve, about the clinical model, well, the evidence hasn't changed, and the evidence that we discussed at the consultations last year hasn't changed, and it still stands that for every person over the age of 75, for every 10 days they spend in hospital, they do lose 10% of their aerobic capacity. They lose 14% of their muscle mass, and that's equivalent to aging 10 years in 10 days. And they also lose their self-confidence as well, and confidence to be able to look after themselves in their own home, and so do their carers. And that is good evidence, and it's supported by the British Geriatric Association, and it's freely available and published. So that hasn't changed, but there are things that have changed in the last year. And we've continued to make progress in developing our intermediate care services. And I've been involved in a project in the last 12 weeks where we've been looking at specifically at care homes and how we provide care in care homes as a multidisciplinary team. And one specific area we've looked at is the beds with care. Specialist beds in the community. And we, as part of that project, we started to look after 3 beds. And at the point that we took on the project, those beds, their usage was 27%. So that was very little usage. We were finding that actually 50% of the patients admitted to those beds were readmitted to the acute hospital within a few days, which is completely inappropriate. We're talking about here the most frail, vulnerable and complex patients in our communities, and these transfers are not good for them. And so after working with the team, that includes OTs, physios, an advanced nurse practitioner, social care, we have turned those beds round, and within 12 weeks, the usage of those beds has gone up to 66%, and we believe that that could be increased even further. The number of readmissions to the acute hospital was 0%. So in a very short period of time, we've actually demonstrated by working, as I say, multidisciplinary teams, using systems so that we approach people in a strategic way. And there is a process called the Community Geriatric Assessment that, again, is well documented and well available to reference. We've actually, as I say, improved the outcome for those patients in those beds. And as a result of that, I feel even more confident about our proposal around offering these beds in communities. So that is one thing. I think the other thing that we've actually done is we've disinvested in some services that were not cost effective, but we've shifted. That was the Falls Partnership service. It wasn't cost effective. It's very expensive. It wasn't working well for us. But we've actually shifted those resources, and we've used those resources to invest in more occupational therapy time, in the AMPs that are working in the integrated care service, and in care coordinators. So I think we've demonstrated that actually we can improve care. We can move clinicians to work in communities and get better outcomes for this group of people.
Great. Thank you very much indeed, Ruth. I think one last thing I just wanted to highlight. We've talked a lot so far this evening about what was in the scope of the consultation. We've not really talked about what wasn't in the scope of the consultation, but which is affected by this evening's decision-making process. So particularly with reference to the two sites potentially at risk of closure, depending on the decisions we're about to make, it is just to reiterate that the other services provided by those units will continue to be provided in those communities. So the physiotherapy, the outpatient clinics and things, again, you will remember back at the time of the consultation, we were quite clear to highlight that those were not part of the process we were consulting on, and that actually we will continue to ensure that those services are available locally to the residents of those communities. I think at this point we're going to draw the group discussion to a close. I'm going to ask North Derbyshire CCG to adjourn. This is purely on the basis of alphabetical order. So Hardwick are going to consider their proposals first. I'm going to ask North Derbyshire colleagues to leave their smart electronic devices or electronic smart devices, whichever way around it is, in the room, because we're asked not to sneak away and watch the live streaming of Hardwick making their decision. But we are going to adjourn for a few minutes for Hardwick to have a further discussion if they wish, and then to make a decision on the proposals, and then we will return as North Derbyshire CCG and do the same before we all come back together at the end of the evening. Thank you very much indeed to our general public for your patience and tolerance so far. We are getting to the end of it, folks.
Okay, if we can just continue with the meeting in terms of the Hardwick conversation. So again, thank you to everybody for their participation. We've obviously had some detailed questions from both members of the public and from our governing bodies. Now's the opportunity if Hardwick colleagues want to ask any further questions or clarification. Can I just check around the table? No? Okay, we're happy. So just to go through the process that we're going to adopt now, basically it's the voting members, so that will be myself, Andy, Miles, Ruth, Jim, Sid, Lucy and Jill. We are now going to have a look at each of the proposals. We normally, through our governing body meetings, as you know, look at these, and if we can have consensus, then we don't have to go to a vote. But if we think that anybody is not convinced by the argument, then we will obviously need to have a vote. So just checking with colleagues, I will go through each of the recommendations and I will ask you if we think we've got a consensus, and if we have, then we will agree the proposal. If not, we will then take a vote, and the vote will be by a show of hands. And it's a majority decision. Okay? That's as per our constitution. So I'm also going to ask Clive just to put up on the screen so everybody can see what the recommendations are. So we have two papers in front of us. The first one is the post-consultation process. So that's the first three recommendations on there. So the first one is to agree the process. The second one is to agree the responses, and the third one is to note the impact of those responses. So that's, for members of the public, that's the first three recommendations on that slide. Can I ask colleagues, do we think we have a consensus?
Yes.
Reasonably comfortable? Okay. So can we agree the process? Yeah?
Yes.
Can we agree the responses?
Yes.
Thank you. And can we note the impact of the responses?
Yeah.
Okay. All happy with those three recommendations? Thank you. We then move on to the second paper, which is the final business case. Now, this is a little bit more detailed, in fact, quite a bit more detailed, in terms of the recommendations here. As Clive said to us, the sections in italics are those amendments that have been made as a result of the consultation and the feedback that we've received. I don't plan to read each of those out, but I will go through each of the headings and make sure that we are happy to agree each of those in turn. So, the governing body is asked to agree the proposals around specialist older people's mental health services, and there are 5 proposals on the screen. Do we think we can reach consensus on that? Yes. Yeah. Are we in agreement those proposals? Yep. Thank you. The next one is around agreeing the proposals around older people's mental health day services, and there are 3 recommendations, which are on the screen. Do we think we can agree to those 3 recommendations?
Yes.
Okay, they are agreed. In relation to the community-bedded care, there are 4 recommendations on the screen in front of us. Do we think we have consensus in relation to those 4 proposals?
Yes.
Okay. Are we happy to agree those proposals?
Yes.
Thank you. Those proposals are agreed. In relation to the other services, there are 4 proposals which are on the screen. Can we agree the proposals in front of us in relation to other services? We have consensus on that. That is agreed. Thank you. And then finally, we have the implementation phase and the proposals around that. There are 7 proposals here. These are all linked to specific feedback from the consultation process. Do we think we can reach consensus on these proposals? Yeah?
Yes.
Okay. So are we agreed in terms of the implementation process? Thank you. So the recommendations on both papers are agreed in consensus with the full governing body membership here present. Can I just ask the Company Secretary if there's anything else we need to do at this point? Okay. So what we will now do is we will invite North Derbyshire back into the room, and Hardwick will absent itself and let North Derbyshire make their decision. Thank you for your cooperation. Can we just... You can just bear with us while our colleagues from North Derbyshire come back into the room. Thank you. Apologies for the slight delay in the process. We are just trying to find our colleagues. We're not quite sure where they've gone to, but... Oh, here they are.
Right. Thank you very much indeed, folks. Brief interlude, if we could just restart again. So now we're just with the North Derbyshire CCG governing body. As you remember at the start, we identified we have a number of voting and non-voting members. Okay, we'll see how the discussion goes, and when we come to making a decision, I'll talk you through how I'd like to do that. But for now, just to reiterate what it is that we're being asked to agree. For those of you who've seen the papers, we have two cover sheets. Effectively, the first one is to review the consultation and to agree the process by which we consulted, reviewed and considered the formal responses. And then the second is the actual proposals themselves, and the governing body is asked to agree the proposals.
How can the board take a decision when they've not been allowed to hear all the questions or all the answers that are given to the
That is up to the governing body to decide. Okay. Please, if I could continue with the business of the meeting. The opportunity now is for the governing body to ask any further questions they may have or seek any further points of clarification before we ask to work through those decisions. Are there no further questions or points of clarification? Debbie and then Steve.
Just to say that obviously we have been through a 3-month consultation process where we have taken questions from the public. I myself and many of us here were involved in that, and obviously we've had all the consultation responses. So in that context, I think we have answered many questions, and I think we are now have then used that in the presentation tonight and now use that in our thoughts as we make the decisions now.
Thanks. Mine's just I suppose it's just a comment really, and it picks up on the theme that Jane was asking about in terms of the governing body taking assurance around the quality and safety in transition. What I thought was really powerful was having the slide which started to show the governance around the sort of implementation. And I think that for me is really crucial. I think we should commit as a governing body that that actually is something that we very, very regularly review and keep under good regulation, because that's actually the meat and drink of making this happen. And if we don't get that right, actually we will get so much wrong.
Absolutely, Steve. Any further points? Comments? Gary?
Yeah, Ben, just to say really, from my perspective as the lay member for public and patient engagement, and I am the voting member, I take my role very seriously in terms of presenting a challenge to the governing body on matters that are brought to my attention, and I'll continue to do that. And you know, we've been doing that now for what, 5 years or so. We've gone through some very difficult issues as a governing body, and we continue to make very, very difficult decisions against a very difficult backdrop. So for me, recognising the question that was posed without wanting to respond to it, but simply to say we'll continue to do what we do by listening to members of the public, and I will be championing those questions and those points through governing body like I always do.
Okay, right. So, as I say, we've got two papers to consider here. So the first is paper B1, which is the post-consultation process and formal response to the consultation, 21st Century Better Care Closer to Home. As it identifies at the top of the cover sheet, the purpose is to agree the process by which we consulted, reviewed and considered the formal proposals. And you'll see on the final page, page 4, item 6 is the recommendations. So I'll just read these through and then clarify what I want to do. Governing body is asked to agree that the process by which we consulted and reviewed, considered all the responses was in line with the gunning principles, including agreeing that the product of consultation has been conscientiously taken into account, that we agree the responses to the consultation, and that we note the impact of the responses on the proposals to be agreed as part of the Community Hub's business case post-consultation for decision. So clearly that's what we've taken everybody through this evening in terms of Clive's presentation. Decision-making with regards to our constitution as a CCG requires me to seek consensus opinion wherever possible. So I'm going to ask perhaps in the first instance if anybody feels they are not able to agree the points that we're asked to do so there. No. In the absence of any dissent, I will take that to be a consensus agreement, therefore, and that we do agree with the 2 points and note the third as we're requested to do. I'll move us on, therefore, to paper B3. Okay, final business case, 21st Century Better Care Closer to Home. Governing body is asked to agree the principles. Now, with regards to the recommendations, this is a slightly more complicated process, because whilst it asks you to agree all the proposals, actually, if you look at the key matters for consideration, point 2, it does take us through all of the quite extensive proposals that we've seen put forward and discussed both through the consultation and then again in terms of the response back tonight. So I'm going to take the 5 areas in turn. So first of all, in terms of specialist older people's mental health, points 1 through to 5. Okay, so establish a specialist inpatient OPMH centre of excellence at Walton, invest in community dementia rapid response teams to work across the 8 communities, to therefore potentially close the current OPMH beds at Cavendish and New Home pending the implementation of the 2 models above, that we continue to commission the respite care in Buxton, and that as part of the implementation proposals that we phase out the provision of functional mental illness care on Spencer Ward. Again, with regards to those 5 proposals, does anybody wish to object to those? Can I assume, therefore, that we have a consensus opinion that we agree to progress those? Yeah, thank you very much indeed. With regards to older people's mental health day services, the proposals would see services currently delivered through the dementia day units instead provided through a combination of services either within people's homes or from sites within the communities. 2, these services will also be better integrated with other community services, including the Integrated Care Service, the Dementia Rapid Response Team, and the Community Mental Health Team. And then finally, as a result of that, a successful implementation of 1 and 2 would mean that the dementia day units at Walton, New Home and Bolsover would potentially no longer be required and could close if that was the case. Again, I ask if there is any objection to those proposals, and therefore take it that constitutes a consensus agreement that we will progress those proposals. Yeah, thank you. Next one, community bedded care. So 1, the local intermediate care beds will be increased from 25 to 44. The integrated care service will be developed to support an additional 1,175 people per annum. So going back to the presentation, the graphic that was put up of the proposed 150 beds or 151 that we will need in the future, that was the 75 beds that will actually be provided as care in people's own homes. Close community beds currently provided in the community hospitals at Bolsover, Claycross, New Home and Whitworth, pending the introduction of those 1 and 2. But that in addition, recognising that some people still will require specialist bedded care, that we develop specialist rehab units on the Chesterfield Royal site, 32 beds in total, 24 of them on the Chesterfield Royal site and 8 on the Cavendish site in Buxton. Again, with regards to the community bedded care, does anybody like to raise an objection to that at all? So we've carried that as a consensus decision. Thank you. So that carries us over to other services. So as we've heard in the presentation, the impact of removing those services is particularly marked on the sites at Bolsover and New Home, and that potentially, if we remove those sites, if we successfully implement the community services, that we would be able to close the sites at New Home and Bolsover. However, as I said earlier on, we commit to continue to deliver the other services currently provided from both sites locally within the communities that they serve, that we continue to review other sites as other service proposals are developed, and we note that these proposals remain subject to review and approval by the provider boards who own the assets to those units. Again, I'm going to ask if there is any fundamental objection to any of those proposals. No, then I consider that we've agreed that by consensus as well. And then finally, I'm going to take us on to the implementation. Bear with me, there's quite a bit of wording on this, folks. So part 1, ensure that implementation principles outlined in this business case are upheld, including that no site or service will be closed unless a clinically suitable alternative has been put in place. Undertake to establish effective governance of the implementation to ensure that it will be managed and governed effectively with care whilst listening to staff and the public. Ensure that the process of equality analysis and due regard is repeated with more detailed consideration as part of the implementation process. Ensure that the implementation process responds to help reduce health inequalities currently seen in Northern Derbyshire and outlined in the Public Health Inequalities Report, pre-consultation business case, stage 4 of the appendices document. Part 5, ensure that the quality impact assessment is repeated during implementation. Part 6, ensure that a comprehensive communication and engagement plan is developed in partnership with patients, staff, carers, and the wider public and other key stakeholder groups. And then finally, 7, ensure effective communication and engagement with patients, staff, carers, and the wider public and other key stakeholder groups. So quite a lot to go through. Appreciate that as we've acknowledged many times this evening, this remains a very contentious set of proposals which are clearly been very difficult both in terms of the consultation process and ongoing discussions. But given the caveats there, is there anything anybody wishes to raise with regards to those? Is there any fundamental objection to any of those? And on that basis, can I assume that we carry that final part with a consensus decision? Thank you very much indeed. Right. Thank you very much. Ladies and gentlemen, you've been incredibly patient and incredibly respectful. If I could just ask you to bear with us for a few more minutes, we'll just get Hardwick back into the room and summarise both decisions. We genuinely, they played it absolutely, don't play poker with anybody from Hardwick CCG, because they did a very good job of not telling us as they walked out of the room what they decided. Oh. Okay. Welcome back to Hardwick CCG colleagues. Jill, I'm going to ask if you could summarise the decision that Hardwick governing body made, please.
Okay, so as I say, we had the two papers in front of us. The first one was the post-consultation process, and I'd like to confirm that the voting members of Hardwick Governing Board agreed all three proposals. And on the second paper, which was the final business case, we went through each of the proposals in detail, and Hardwick Governing Body approved all of the recommendations within the paper.
Equally, I confirm on behalf of North Derbyshire CCG, likewise, we considered the first paper B1 and were able to agree both of the recommendations and note the impact of responses we were asked to. And likewise, in considering paper B3, we went through the matters for consideration, considering each of the 5 areas separately, and were able to reach a consensus agreement on all of those and agreed proposals. Do you want to read out that?
Thank you for that. That's really helpful. So in terms of the next steps, I guess we just need to make sure that as both governing bodies have agreed the proposals, we've reached the decision and we're now moving on to the implementation phase. As we said before, we will ensure that we keep people posted on the process. There will be information on the website, and we will work with partners and members of the public in terms of that implementation process. I'd just like to say from on behalf of the governing body members from Hardwick, thank you to everybody who's participated this evening. Thank you for the contributions you've made as part of the consultation process. Thank you to colleagues on the governing bodies for their time and energy in terms of the decision-making process, and to our colleagues back at base who put an inordinate amount of time and effort into getting us to this position. So thank you. I'll just hand back to Ben in terms of closing remarks.
Likewise, I think, to thank colleagues from both CCGs, both those in the room and those not here tonight, who, as you say, have put in the most fantastic amount of work. A huge thank you to you, the general public, not only for your engagement tonight, but your engagement throughout the consultation process last year. I appreciate that you will be disappointed in terms of some of the decisions that you've seen taken tonight, but I would genuinely ask that you continue to engage with this process and support us, because we, as I think you've heard, thank you, but as you have heard tonight, there is very strong clinical support for the new model of care, and it can, with your help, be made to work, and be made to work very successfully. I've got on my agenda as the final business the date and time of the next meeting, which, for anybody interested, those of us in North Derbyshire are back doing this again on Thursday afternoon for our normal monthly governing body, which again is held in public. But otherwise, that is this evening's business concluded. Thank you very much indeed, folks, and thank you for your time and your patience this evening.